everyone. I want to first thank you for watching, but I also want to wish you a very happy Women's Month. My name is Rita, and I am a senior public health educator with the Ending the HIV Epidemic team at the Detroit Health Department. Today, we're here to talk about women and HIV. When you're in the community and doing this work, often the unique needs of women are not discussed. So we wanted to take some time in celebration of Women's Month to just talk about the atmosphere of women in HIV prevention and care for women of color, for the LGBTQ community, and particularly here in our own community of Detroit. Today we have with us Famika Edmonds. She is just an all-star in this HIV work and our subject matter expert for today. Born and raised in Queens, New York until she was 10, Famika now resides in Royal Oak, Michigan. She's been employed with the Detroit Health Department since 2017. Before that, Famika worked in previous positions that promoted health and wellness for the community. She is currently a program analyst for the Detroit Health Department's Ryan White program. Her work at the health department has afforded her the opportunity to do such healthcare segments like Lavonia Perryman's show on 9:10 a.m. Superstation. She also has an empowerment organization called For the Love of Her, which she started in 2018. Her goal for wanting to create the program was the need for women to have a safe space to be able to express themselves and be supported by other women. She facilitates workshops and does empowerment speaking engagements. During the pandemic, she launched a podcast that tackles issues that are impacting Black women and girls in our community. Currently, she is facilitating workshops for the Full and Fabulous Project, where she works with young girls from the ages of 9 to 18. If she isn't a powerhouse as in her free time, she enjoys traveling, spending time with family, going to new restaurants and visiting wine bars, watching movies, and doing community service work with her sorority, Zeta Phi Beta Sorority Incorporated. She also has a master's in health administration, and we are just so glad to have her here today. Famika, thank you so much for being here today. I know that you are a busy woman, and we just really appreciate you taking time out of your schedule to come and have this talk with us.
Well, thank you. I appreciate it. I think it's definitely a much needed platform that needs to be spoke about, especially when it comes to Black women. A lot of times we are not recognized, and even if we are sitting at the table, when our voices are not heard. So I thank you for being able to put this out there.
Absolutely, I 100% agree. So we're here today to get your expert opinion on the landscape of HIV as it relates to women, cis and trans, particularly of color. So tell me, what are some of the social determinants of health that have an impact on women?
Okay, so the factors that contribute to a person's current state of health, these factors usually are biological. They are usually social, economic, psychosocial, or behavior or social in nature. So some of the things that did come out of a lot of the research about that is impacting the cis and transgender Black women community is usually economic security, for one. Also, you see a lot of homelessness. Intimate partner violence, you see a lot of it with both cis and trans women. Also, we do have a high rate with maternal health, especially when it comes to mortality, when it comes to Black women and carrying their babies and stuff. Many times it's coming because they're not being provided health access. Many times they're not going to their prenatal appointments. Certain things are not being diagnosed in a timely manner. So we do see a high rate of infant maternal mortality when it comes to Black women. Also, when it comes to the the LGBT community, as far as lesbian and bi women, we do have a high rate of cancer as far as cervical and breast cancer. And many times it's because we're not being provided the screenings that we need at that time.
That's really powerful, especially when it comes to Black maternal infant health mortality. A lot of people don't realize the level of stress and anxiety that come with being pregnant. And then you add in the additional factor of potentially being HIV positive and what those mothers have to go through. So what other health disparities or health inequities do you think Black women face today?
When we discuss health inequities, we have to also look, because it's a twofer when it comes to Black women. We are not just being discriminated because of our race, but we're also being discriminated because of our gender. Mm-hmm. So it's a twofer. And now if you're a trans woman, now you're also being discriminated because of your sexuality and also your gender. So you got all of that coupled. And so these are things, and it's a lot of intersectionality that we have to deal with. A lot of it deals with the structural barriers that we face when we go into the healthcare field.
And how do you think that kind of affects the care that women are getting when it comes to their HIV status? Do you feel like it's more difficult for them to get care or access care or be treated fairly?
In my time of working in the HIV field, I felt like when it came to cis, heterosexual, and women that identify as women who have sex with women, a lot of times we are not usually the ones that are having those conversations, or even if funding is even being put towards our health when it comes to HIV, because a lot of times we're not considered as being at a higher risk as our transgender women counterparts. Mm-hmm. Many times, because they do have a higher risk factor, that's where all the focus is put on, and it's not put on us. And so when it comes to even looking at numbers, a lot of times the numbers are not accurate when it comes to the percentage of Black women who are actually infected or impacted by HIV. So a lot of times those conversations, again, are not being had when it comes to cis, heterosexual, and women who have sex with women.
Wow. So what are the leading causes for health disparities amongst Black women, cis or trans, or just women in general?
I think I'm gonna break it down. So for transgender women, a lot of times their health disparities are that they have a higher risk with HIV, and a lot of that comes to deal with sometimes their lifestyle and the choices that they have to make, because if many of them have to resort to doing sex work, and unfortunately that has been the problem in the past for many of them. Thank God now a lot of doors are opening where transgender women are being able to be employed and have employment where they don't have to resort to going to sex work, but it does put them in more of a higher risk when they have to resort to doing sex work. A lot of times too, their health disparities come from the fact that their mental health, dealing with not having the support from family members or even the support that they need from the community. A lot of times they're dealing with mental health issues that are not being addressed. They also deal with a lot of homelessness, and because of that, if I'm homeless, the last thing I'm going to be thinking about is going and getting treated or staying in compliance with my medication and adhering to my appointments. So, that's something definitely that impacts that community, that demographic, because of the fact of them being, many of them are homeless. Also, if they are taking hormones, a lot of times it puts them at a higher risk for cardiovascular disease. So, with that being said, if they're not going to their appointments the way that they need, a lot of times those issues are not being addressed the way they need to. And then when we go to our cis women, Black women, we some of the health disparities I feel that we're facing is our race and our gender, because many times when we do go and seek medical care, we may not be getting the access to the care, and then we also are faced with a lot of implicit biases that we face when we do go to our providers. I'm not saying it's everybody, but a lot of times we do get faced with it. Many times they don't think the problems that we're dealing with are the same problems that our white counterparts are having. I've seen research where when it comes to cis heterosexual women, that Black women, that they feel that we can tolerate pain better than white women. So a lot of times if a woman presents and they are having issues with headaches and stuff, the first thing that they're saying is that we want to get medication for whatever habits, and we might not even have a habit, but yet and still our same white counterpart will get the script and get the help that she needs if she comes and she says that she's having the same symptoms. So those implicit biases and stereotypes, I think they keep perpetuating how our care is in the healthcare field.
Absolutely. It's just like a different set of standards when you go to the doctor. You just never know, or you have to be really intentional about finding that doctor that really wants to listen to you.
Correct.
And take those issues that you're bringing to them into real consideration, or you have to really be able to advocate for yourself, which I know can sometimes be really, really hard for women in general. And then you keep to like narrowing down, adding all these other layers of like Black women, you know, maybe women who have sex with women, trans women, and it just gets tougher and tougher for them to really advocate for their health.
And can I just speak on a personal experience for myself? Being a woman that identifies, I don't like putting titles to stuff, but I'm a woman who has sex with women. And I'm an older woman, and when I did come out, I came out later in life. A lot of reasons is because of how I grew up. It was not something that you just came out and discussed. It was very taboo growing up. But in being able to go and get care, a lot of times I did not want to have those conversations with my provider because of the fact I did not want to be judged. I didn't want to be looked down on or stigmatized because of the fact of who I love. And then I know one time I did go to the doctor and I usually do a full panel whenever I go and get tested, get my annual, I get tested for HIV, everything, all that, okay? First thing my physician said to me, well, you're having sex with women, so why would your risk factors be high? Yeah, and so it was an education moment for me with her, because I just couldn't believe she even said that to me. But the first thing that I said to her was that regardless if I'm having sex with a man or a woman, I still need to make sure I'm okay.
Healthy, safe.
Exactly. 2, she didn't even want to do my pap smear for that year because she felt like because I didn't have sex with a man that I didn't have the same risk factors, I still can be at risk for cervical cancer. So when you don't offer those screenings, you are putting this person's risk factors in a higher place, because these are things that have to be done. And you're absolutely right as far as about being an advocate for yourself. We have to know when we need to be screened for certain things. And if you ever feel at any point that you know that you are not getting the services or the screenings that you need at the time, and the doctor sits there and says there's a reason why they're not doing it, they need to document why they're not going to give you those screenings. So you definitely have to be an advocate. Find out when you are due each screening during the course of your life, and that way if these things are not being offered to you, you definitely need to be speaking up and advocating for yourself.
Well, thank goodness that provider, came across your path. And you were able to educate in that moment. But you have a master's in health administration. You do this work, so you can speak in an educated way to a provider about why that approach wasn't the correct one to take.
Right.
But can you imagine if it was, another counterpart that maybe is not as well versed in these topics or not as well educated, and they're relying on their provider to give them the information that they need, and they're not getting it. So that's why it's really important that in the work that we do in HIV, that if people are not equipped with the tools to advocate for themselves, that there are people doing the work that can help them advocate and keep them educated, which is why I'm so glad we're having this conversation today, because now somebody watching this video can take away something that they can take to their doctor and be more educated about.
And I think too, for women, it's so important, even if you're not having sex and you're abstaining to abstinence, even if you decide, for me, even if I'm not having sex, it's just routine to get these testing. So I'm in the mode of doing it each year. And then if you do decide you want to engage in sex, have that conversation with your partner.
Absolutely.
And make sure that you know what their status is, as well as you knowing what your status is, and going into it. Go get tested together.
You
know, so that way
we're gonna go get tested. We're gonna go have dinner. Go have some drinks.
And let's get tested. So that way you know what you're walking into, and unfortunately, if something does happen, you know where you got it from.
Absolutely.
You know, so, and it's important to have these conversations. And I think too, a lot of times as Black women, we don't feel that it's appropriate for us to sometimes have these conversations. But my thing is, this is your body, this is your temple. You should be making sure that you keeping it as good and as healthy as possible. And before you engage in anything with anybody else, you should know what's going on with them prior to you engaging with them. So no, I think education and awareness is key to people being a better advocate for themselves, though.
But that also brings up, like, almost to play devil's advocate. You know, it's better to have a plan for sex like that, but we all know that it doesn't always happen. Okay. Nope. So you're not always going to have the opportunity to say, hey, let's go to the doctor and get tested before we lay down and have sex after we just left the bar. So it's just really important for women, cis and trans, to feel empowered to have their own prevention mechanisms on them. Go to the store, buy that pack of condoms, female condoms. Have conversations about PrEP, especially when we're talking about HIV and preventing that in women. Like, let's talk about PrEP, because a lot of the messaging and education that's created around PrEP isn't tailored to women, so they don't know that they can take it, but they absolutely can. So we need to have the tools to protect ourselves and strengthen those prevention and care efforts. Do you have any other suggestions when it comes to strengthening prevention and care efforts and closing that racial disparity gap in HIV infection among women?
Well, first of all, I think the messaging is key, because like you had stated, the messaging has not been tailored to Black women. It has always been tailored, and luckily it has been tailored somewhat to the trans women, but it has not been tailored to cis heterosexual women. It hasn't. And I know one time in my works and trying to do outreach about PrEP, when we really was starting to get PrEP out here, that many women did not realize, and it was both Black and white women, did not realize that they can actually take it, because the messaging was it was for gay men and trans women.
So which happens a lot.
It does. So we have to start changing the narrative and how we put our messaging out there. It needs to be tailored to everybody, because HIV does not just affect gay and trans women. It affects everybody. It affects babies. It affects kids. It affects women. It affects men. It affects older people. So, and with the education part, we really need to look at everybody as a risk factor. So, as you said, we have to be accountable for our own health. I can't take, that the person that I do lay down with, they're going to be forthcoming. Because I also used to do health threat cases when I first came to the health department. And some of the cases that we did come across, many times, their partners didn't even know that the person even had HIV. They did not tell them. I had to be the first person to tell them about their diagnosis and them being exposed. I couldn't tell them who they got exposed by, but just to have that conversation. And many times it was Black women who thought that their husband was doing what they were supposed to be doing, and they were being faithful to them. I think for us to be able to narrow things down and really address health equity and making sure that everyone is being equally represented, we definitely have to look at the racial discrimination that heterosexual Black women face. That is definitely something, and we also need to change the narrative and bring more education and awareness to the risk factors that Black women do have.
So that's really great information, Famika. Thank you. We've talked today a lot about disparities with women. We've talked a lot about difficulties with healthcare access. and experiencing stigma and those like experiences they have with providers, and just, you know, with HIV transmission in general. So I guess the next step would be to ask, how do we fix that? What is the solution? How do we reduce those disparities and barriers and give them increased access to health care, and overall, which is probably one of the biggest barriers, and reduce stigma?
So some of the ways that we can reduce the disparities that we see that impact cis and transgender women, Black women, let me say that because trust me, Black women and the things that they experience is totally different than our white counterparts. So I think, one, definitely education. You doing something like this, we definitely need that. If we're going to be at the table, we can't just make sure that we're taking care of all the other demographics. We also got to be a voice and an advocate for ourselves. Because one thing about Black women, we are nurturers, and we're going to make sure everybody else is good, and we don't always pour back into ourselves. And I find a lot of times we don't pour back into our community. So being at the table and making sure that our voices are being heard, bringing more awareness to the disparities that are impacting us, and also providing spaces where we do have access to healthcare, knowing, you know, where we can get education so that we don't have to settle with low income jobs. But a lot of that is knowing where these things are. So a lot of outreach needs to be put out. Messaging has to definitely be put out. And the messaging needs to be geared towards that demographic. A lot of it is not being put out there for cis Black women. So a lot of times we don't know where to go. When it came to even here in Detroit, you have to realize they went through the bankruptcy back in 2015. So when that happened, Herman Kiefer, as everybody knew, was no longer around. So a lot of people did not know where to access healthcare at that point and where to go and everything. So I think doing outreach in the community and making sure that we are targeting, just like we have target different demographics because we felt they were at risk, we have to start doing it for our Black cis women. Target that community. Get the information out to them. Meet them where they're at. I think if we start meeting people where they're at, yeah, they'll know where to go, you know? So I think that's key. We definitely have to start being more culturally competent about different cultures and people's gender and everything. And that, I think, goes back to people who are going to medical school and nursing school, making sure that they have classes on cultural competency in our workspaces to make sure people are treating people with equally as they are other counterparts. So being able to have those spaces and the knowledge and having those resources available. But definitely we have to be out there on the streets, getting out there in the throes of stuff and letting people know where they can get the resources. Because a lot of times they may not know. One of the things that I think COVID did shine a light on is a lot of the health disparities that are faced with Black women. Because many of us were the essential workers. Many of us are in healthcare. So many of us was the frontline workers and had to get out there. And we're the single moms who did not have the resources that we need to take care of our kids while we went out there. So I really think we have to make it where even if you don't know where to go get it, I'm going to bring it to you so you know where to go get it.
I think that is so important, talking about outreach, talking about education, and increasing access. And although it is very important to highlight Black women, when we're talking about women of color, we're also talking about our Latinx sisters, our Native and Indigenous sisters, Asian women. All of these things tie under this umbrella of women of color. And HIV doesn't discriminate.
No, it does not.
So we need to make sure that all of the issues and barriers faced by all women of color are addressed too, because even when you go into those other categories of women of color, you're more likely to deal with even more barriers, language barriers, things like that. So I think that's a really, really important point that you made. And I'm so glad that we are able to have this talk and share this information. So that's really all I have for today. Do you have any final thoughts that you want to get out there before the camera stops rolling?
I do. And I just wanted to say, since you did bring up about our indigenous sisters and, our Latin sisters, we also have to be mindful when we are doing our messaging. We sometimes have to have someone who looks like you to represent you. So then that way, because a lot of times as healthcare providers, we got to also realize there's trust factors that people may have with going to their health providers and receiving care and getting the information that they may give them. I may not trust you because, first of all, I'm a Black woman and I already see in how that we have been mistreated over time. So just looking about how our ancestors might have been treated within healthcare, I have my issues sometimes with the healthcare and with the healthcare I'm providing. So just think about someone who's indigenous, and most of them have lived on a reservation, and their perception about the outside world. So when we do put that messaging out there, we have to be mindful about that as well. And that we are meeting them where they're at. And if that means that it's somebody who looks like them representing them to get that messaging, then that's something we may have to look at doing as well.
Absolutely. It's so powerful. So thank you so much. So again, I just want to give a huge thanks to Famika Edmonds for being here with us today and having this conversation. I just want to leave you with a final thought that to achieve true health equity for all demographics, we must bring awareness and cultural competency to the education that we're giving and start removing those structural barriers that each demographic faces. This conversation was so needed and so important. I thank you for taking the time to watch. Again, my name is Rita Little. I'm a senior public health educator with Ending the HIV Epidemic, and we are here to do whatever we can in this community to help reach that goal of ending the HIV epidemic. So you will see my email pop up shortly. If you have any questions or are looking for resources, please reach out to me, and we're going to get you the help that you need.